Good morning. Welcome to Palliative Care Grand Rounds. It is my great pleasure this morning to introduce Dr. Dan Sulmasy. He is the Kilbride-Clinton Professor of Medicine and Ethics at the Department of Medicine and Divinity School at the University of Chicago, where he serves as the Associate Director for the McLean Center for Clinical Medical Ethics. He's held a variety of positions in ethics at a variety of different institutions, did a lot of his training at Johns Hopkins, has really been a leader in ethics and sort of this bioethics and thinking about end-of-life care. His research interests include both theoretical and empirical investigations of ethics and end-of-life decision-making. He's an author of many books, The Healer's Calling, Methods in Medical Ethics, and he serves as the editor-in-chief of the Journal of Theoretical Medicine and Bioethics. I found out from Dan today, although I have respected him for years and years, many of you know I'm a Midwesterner, he is a Packer fan. So although I have held him in high esteem, he has now gone right up here. So we're very pleased to have Dan today talking to us about the Book of Numbers, Measuring Spirituality in the Care at the End of Life. Welcome, Dan.
Thanks for the gracious introduction, for the invitation to be here. Although you elevated me on a pedestal, I have to say that being in this historic room is humbling for any speaker, so I'm grateful for that as well. I wanted to talk today about empirical research about spirituality at the end of life, and to not do so much talking about specific results as much as to talk about questions in measurement, questions about the promises and some of the limitations in what we can do with empirical methodology, looking at spirituality and caring for patients at the end of life. My caveat there is that while I'm on the U.S. Presidential Commission for the Study of Bioethical Issues, these are my ideas and have nothing to do with the Commission. I have to give you my objectives to be able to distinguish spirituality from religion, describe the complex relationship between spirituality, religion, quality of life, and satisfaction with care. If you can do that, that's really great. I'm not sure I can. And then explain why controlled trials of intercessory prayer are flawed scientifically, morally, and theologically. Otherwise, I'd be all for them. So we'll get to that at the very end. I also am supposed to give you disclosures. So here are mine. I am a general internist and a philosopher for 25 years. I was a Franciscan friar living a vow of poverty. No manufacturers of drugs or medical devices are interested enough in my work to have ever given me any money. I own no stock in any corporation other than 1 share of the Green Bay Packers and 3 shares of the Seminary Book Co-op of Chicago. I have no relevant conflicts to report. With that done, let's explain why no drug companies are interested in my work. I think I try to begin by placing all of the questions about spirituality and end-of-life care in a deeper kind of context, and to say that there are, in some ways, 2 central mysteries to being human. One of those is existence. No matter how good genetic engineering ever becomes, you will never be able to choose your biological parents, right? The fact that we exist is something totally out of our control. Nor, no matter how good regenerative medicine ever becomes, will we ever be able to make ourselves immortal. Existence and finitude are givens of us as human beings. And the task of medical care is actually right in the nexus of our existence and our finitude. We help to usher in and to maintain existence, and we minister to the finitude of the body that's the occasion of medical suffering, right? So pain and suffering are different. We all know that, particularly in palliative care. Part of the way I explain this is that the pain of arthritis hurts, but it becomes suffering the moment you can't open a jar or have difficulty doing it, when it reminds you of your finitude. And there's a way in which, every drop of blood, every wave of nausea, every creak in the bones, every increase in the diopters on your prescription for glasses reminds you of your finitude. And that's the real occasion for our suffering. Now, there have been lots of attempts in the past to be more inclusive in medicine. We know about the biopsychosocial model of Engel, the ecological model of White, trying to expand the focus of medical care beyond merely concentrating on the body and to think of it in this whole person context of human beings. But they've not been, actually fully integrated into medicine as it is, and I'm going to try to expand it even more, which makes life difficult. Because spirituality is not part of either of those models, and that's part of what I want to integrate into our care for patients. Our existence is a mystery, our finitude is a mystery, and being a person is a mystery. Again, the mystery of the person is perhaps the axis around which the double helix is wound, right? There's nothing substantive in there, but all the substance is in the mystery of the person that we're called to serve as healthcare professionals. Now, here are my definitions for spirituality and religion, and trying to distinguish them. You'll probably see a variety of these in the literature. But my way of thinking about spirituality is that it's one's relationship with what transcends one's finitude. The question is there anything beyond our finitude as human beings? And people live their lives in accordance to the answer they have to that question. And even if the answer is that there is nothing, then that person has to live a life in relationship to that question of transcendence, which is always before us as human beings. By contrast, a religion is a set of beliefs, practices, texts, and a community gathered around a common notion of the transcendent. I actually don't believe, as Wittgenstein said of language, there are no private languages. I don't believe there are any private religions. There is always a community, a group, a tradition, a context, rituals, texts, and some shared understanding that makes something a religion. And while in a sense spirituality is in this way broader than religion, it's also narrower in the sense that within every religion, any adherent to that religion is going to have his or her own particular way of relating to the questions of transcendence, even if they are articulated in a common language. And so spirituality is at once more personal and particular than religion, as well as broader than religion. The human person that we care for in medicine, nursing, psychology, the other healing arts, is a being in relationship. A relationship that we all have within ourselves, with others, and with these questions of transcendence. And healing, if you think about it, is in fact the restoration of right relationships. I mean, what is cancer, after all, right? But a way in which the relationships between one cell and its neighbors has gone awry. What is diabetes except a distortion in the proper relationship that insulin and glucagon and the liver and the muscle cells and the pancreas all ought to have to one another. When we heal a person, we are actually restoring relationships within that person. The pathophysiology gets restored to its baseline. We talked about the milieu intérieur of the person, and those are the relationships inside the person. But if we take this biopsychosocial spiritual model seriously, then the relationships are not just inside the person that are important when someone is sick, but outside the person as well. Because illness, actually, in many ways, we all recognize is a spiritual event. right? It disrupts relationships not only within that person, but their relationship to their spouse, to their family, to their communities, and also to their conception of God. And so there is also disrupted by illness a milieu divin. Now, there's been a lot of interest in spirituality and medicine in the last couple of decades, really. And I want to share with you some thoughts about why that might be. Why is there all this interest now? I think part of it is that when medicine is conceived of as only a science, and there's so much push towards that, that it's really run aground, first for patients, and then I think increasingly for practitioners as well. Medicine might be the last bastion of logical positivism, right? The belief that nothing exists except what can be empirically verified. And the physicists have given that up a long time ago, but we still seem to cling to it. In fact, when you think about images in clinical medicine and the e-versions of it in the New England Journal of Medicine, it's all about what you can see, right? But as Frank Davidoff once suggested, who has seen a blood sugar, right? There are things that we have to look at in healthcare that are really a complex set of relationships. And I think there's been an experience for patients of alienation from healthcare, a disruption of relationships even with the healthcare system and their own practitioners, and increasingly, I think, for practitioners themselves, a sense of alienation from the art. And so to illustrate this, I'm going to show you a series of paintings. One of them here is from Sir Luke Fildus, the doctor, and I want you to notice where everyone's looking in this picture. Right? Everyone is, in fact, the doctor is looking at the child, the father is looking at the child is the focus. And that was our traditional model of the proper relationship between family and patient and doctor and patient, right? What we see just a few years later, very presciently, is this painting painted just a few years later. Anybody recognize this painting or the artist? This is Pablo Picasso at the age of 18. Okay? And it's called Ciencia y Caridad, Science and Charity. And Picasso already, just a few years after Sir Luke Fildus, sees the divide between the two. Where is the doctor looking in this picture? Ciencia, at his watch, measuring, right? It's only the sister and nurse and the child who are looking at the patient and giving her the cup of water. So we see here a split that's happening. That's part of the alienation, and interestingly, I think it's been amplified by our technology. The next, so this is Picasso's Ciencia y Caridad, 1897. The next, this is a picture that was drawn by a Finnish artist that I met at the European Society of Philosophy and Medicine a few years ago, who spent some time in a hospital just drawing clinical events. And this, in this case, we have where is the clinical gaze? It used to be on the patient, right? Then it's the doctor's looking at the watch. Now, where's everybody looking? The technician and the patient are not looking at the womb, right, where we have the actual event, but we're looking at the abstraction of this. A bunch of electrons on a screen are where the clinical gaze is. So the action is in the patient and in her gravid state, and our abstraction is to look at a screen, and that's both patients and clinicians. So we wonder where a sense of alienation is. I think we can just sort of trace it through artwork. But as I suggested before, human beings are beings in relationship, and there are intrapersonal relationships and extrapersonal relationships, right? Intrapersonally, we talked about the physical relationships of body parts, organelles, organs, physiological and biochemical processes. There are mind-body relationships, certainly, that we're all aware of. But there are also these extrapersonal experiences that are part of the experience of the patient in these relationships, with the physical environment, with the interpersonal environment, with family, friends, communities, and political order, and also relationships with the questions of transcendence, all part of the event of illness for each individual patient. So because of this, I think there's been a great urge, as people become aware of the importance of spirituality in healthcare, to measure things. I want to suggest in the rest of this talk that I'm in favor of measuring, but I want to be also very cautious about the measuring. I have to say that just a few months ago at a conference, in response to one of my questions, I was horrified actually by the response of one of my colleagues. When I asked her about the limits of measurement, she said, in principle, there is nothing about human spirituality that cannot be measured. This seems to me to actually be perhaps medical positivism, even creeping into thinking about spirituality. And I think also sometimes we've got to just be careful about our urge to measure being something that we do in order to communicate. So we want to be able to get grants, we want to be able to get papers into journals, so we're going to measure because that's what the way we can communicate with the rest of our colleagues. But it's a two-edged sword, and we ought to be very cautious about this. On the one hand, it might be great that we get people's attention about the spiritual, but we may, in fact, have already conceded the entire notion of spirituality and subsumed it under a category where it doesn't belong, simply in order to try to communicate. So I think we've got to be careful about that. And it's also a really tough task, just given the kind of medical positivism and the sort of attitudes about measurement that are so pervasive in healthcare these days. And to just illustrate how tough this task is, I recently published a paper in the Journal of Pain and Symptom Management, and you get the page proofs back. I want you to look at author query 4. You might not be able to read it very carefully, but it says, please provide the first name for the author Aristotle in reference 1. That's what we're up against, when we're beginning to think about something as broad as spirituality in healthcare. So the question I just want to start out with from the point of caution is, can one measure the transcendent? And I think the answer has to be absolutely not. Infinity, whether you put it in the numerator or the denominator, is going to wreck your calculus, right? So we've got to be very careful about what it is we think we're even actually doing when we're trying to measure spirituality. Not all possible questions you could ask if you're trying to formulate a scale or a questionnaire are well formed. So, for instance, on a scale of 1 to 10, if you were to ask a Christian, how much do you need the love of God? I mean, that shouldn't even compute, right? Let's say you're a devout Muslim, right? How much mercy is God, Allah the Merciful, showing you right now? Again, it shouldn't even compute for someone who actually believes in the infinite mercy of Allah. How would you rate your relationship with God on a scale of 1 to 10? There's something that ought to make us very nervous about those kinds of questions. On the other hand, I think we can measure beliefs, attitudes, and behaviors that are related to spirituality. And as long as we're properly cautious about what we're doing, those things can be measured and can be used successfully in investigations of care for patients in all stages of illness, but particularly at the end of life. So I think we can measure beliefs that persons have about the transcendent, about religion, about the existence or non-existence of a deity. We can measure attitudes that patients have. We can measure their emotional states related to questions about religion and spirituality. We can measure their behaviors. Do they attend religious services? Do they read particular texts? We can ask them what they think their needs are from the healthcare system with respect to their spirituality. And then we can look at associations between these kinds of things that we can measure and then other kinds of things that have become more standard in health services research, such as quality of life or quality of care or healthcare outcomes. So I want to give you at least some representative studies on beliefs and attitudes. Things that you may have seen before, but if you're not aware of them, depending on the survey, and how the questions are phrased, and the population, although it does tend to skew more toward the high side, between 41 and 91% of patients surveyed want their physicians to discuss spiritual issues with them. And if you're not aware of that, it's important to recognize that that's what patients are saying. Even 45% of non-religious patients who believe themselves to be spiritual but not religious want their physicians to inquire about their spiritual needs. In one survey, which was in the Appalachian area of Pennsylvania, 48% of patients said they wanted their physicians to pray with them. And again, if you're not aware of these kinds of things, these surveys can help to make you aware of what patients are actually saying. Just give you an example of some studies that were done not in Appalachia, but in Greenwich Village and Chelsea, where 70% of the patients say they're spiritual but not religious. 58% of those patients in an oncology ambulatory care setting said that it was appropriate for a physician to inquire about their spiritual needs. 6% reported that the staff actually had, and 1% said that their physician had actually inquired about their spiritual needs. You can look at associations, as I said, between these kinds of things and some more standard measures in health services research. So again, from that same study, we found that there was the single biggest predictor of a patient saying that they were dissatisfied with their care was saying that their spiritual needs had not been met. Okay? That was bigger than even their rating of the bedside manner of the physician, so pretty significant. And that was in our study in New York. Far Curlin and his colleagues at the University of Chicago, in their hospitalist study, found that patients who discussed religious or spiritual concerns with the hospital staff were more likely to be satisfied with their medical care, regardless of whether or not they wanted such discussions to occur. Interesting from the chaplain's perspective that patients will often not check off the button of the box that says, I want the chaplain to visit, but if somebody does nonetheless, they're open to it. This is sort of illustrated by Ezra Pound's poem. He says, she's dying piecemeal of a sort of emotional anemia. She wants desperately for someone to speak to her and is almost afraid that I will commit that indiscretion. Right? We sometimes put people off from what are our deepest needs. I think that applies probably more to healthcare professionals than it does to patients even, but it did in this study. So what are the kinds of domains that I think are amenable to measurement in spirituality, if you want to drill down a little bit more here? Well, one thing that I think you can measure is religiosity. In various ways. For example, you can measure the strength of a person's belief, at least as they would self-report that. You could measure their prayer and worship practices. So the most common one is attendance at religious services. And you can measure something called the difference between intrinsic and extrinsic religiosity. Someone who has intrinsic religiosity is someone who's internally motivated to be someone who worships or prays or does good deeds, and versus someone whose motivation is extrinsic, who's motivated to do so for other kinds of gains, what other people think of them, if it's the most common example of extrinsic religiosity often given is the politician who goes to church and really doesn't care much about it, but wants to get votes, right? So those kinds of things would be an extrinsic religiosity. You can also measure spiritual or religious coping. Measures have been developed to look at response to stress in terms of religious ideas and language, attitudes, and practices. And there's some scales that have been pretty well validated to look at that. I'll get into it. You can measure a little bit more. I have a little more questions about this one. People have attempted to measure spiritual well-being. The spiritual state or level of spiritual distress is a dimension of quality of life, or maybe a contributor to quality of life, depending on how it's been construed in various scales. And then you can measure spiritual needs, and what do patients actually say they want from healthcare professionals or chaplains in terms of conversation, visits, prayer, ritual. What are the spiritual issues that they want help with? Those sorts of things. So these, I think, are amenable to some attempts at measurement. For religiosity, just to get into this in a little bit more detail, the importance is to go beyond denomination. When people have done surveys, asking somebody what their religious denomination is, at least in the United States, has almost no impact on anything. But you probably want something more about, how deeply they identify with that denomination, how much they actually practice, whatever that might be. People have done some studies I'll get to in the end about religiosity and long-term healthcare outcomes, and I spoke a little bit about intrinsic versus extrinsic religiosity before. Coping. How well do people cope with the stress of illness, and to what extent are they relying on religion or spirituality to do this? What are their internal resources? What are their external resources for this? There are some decent measures for this. The most commonly used one is something called the RCOPE. There's also something called In Spirit. And these are measures of how, whether the patient is coping positively or negatively, because that's another important aspect of this, is that the mere fact that someone is coping and using religion or religiosity as a way to deal with the stress of illness doesn't mean it's actually positive. So patients may in fact be very distressed. They may feel very guilty. They may feel God is punishing them, etc. And these kinds of measures are sensitive to both positive and negative ways of coping. You can also measure religious support. So to what extent do people have a sort of external coping mechanism, a sort of a subset of social support, the spiritual support for patients. Spiritual well-being, I'm a little more skeptical about. The World Health Organization says it's a dimension of quality of life. Probably the most commonly used measure for this is the FACET SP for spirituality. There's a spiritual well-being scale. There's a meaning in life scale. The McGill quality of life scale is used commonly in end-of-life care. Many of you may be aware of the fact that actually on this scale, the spiritual dimension accounts for almost all the variants. So people will say, how's your activities of daily living? Okay. How's your pain? Okay. How's your nausea? Could be better. How's your spiritual coping? How's your spiritual life? Outstanding. How's your overall quality of life? Outstanding. Right? This is the way patients at the end of life will, the spiritual dimension of that is the main driver of the overall scale. My caution about this, though, is that when we're measuring somebody's spiritual well-being, it may be that we've got a sort of bias that it's got to be good and the patient's got to be happy in order for this to be a good thing for the patient. Now, what if the patient was actually a rotten, miserable person who cheated in business, was unfaithful to a spouse, was lying all the time, greedy? Maybe as they're approaching the end of life, they're having some incredible conversion experience, and it's not so. Their spiritual well-being, like Mr. Scrooge, right, may not be so good. You may be very disturbed by what's happening, but that may be a good thing. All right, or you may, in fact, like the mystic Saint John of the Cross, similarly Mother Teresa, experiencing a period of terrible spiritual dryness at a point where one is, in fact, immensely close to God in that period of spiritual dryness. So I don't think that these measures really capture those kinds of broader senses of spiritual well-being that one would think about from a broader theological perspective. And so I'm cautious about some of these spiritual well-being measures. What about spiritual needs? Qualitative data suggests that the needs that patients have from a spiritual perspective are great. And there are lots of studies that show, as a single item, do you have spiritual needs? Would you want the doctor to address your spiritual needs? Patients affirm these kinds of questions. But there really aren't any well-developed assessment tools for spiritual needs, nor are there ways of distinguishing among the various aspects of this. And this is the one thing that I've been dabbling in terms of measurement over the last few years, and I'm going to go through some of this in detail with you in the hope that it might be illustrative of the kind of work that's necessary, I think, to look at some of these kinds of questions more deeply. So this was published last year in the Journal of Pain and Symptom Management. We call it the SNAP, the Spiritual Needs Assessment for Patients. It's an instrument to try to assess unmet spiritual needs. And we started with a publication from Alison Modal. She had a kind of a loosely constructed scale with some questions that we thought were pretty important. But we also thought it was kind of narrow. There was another list of potential items that might be spiritual needs that patients had that were developed by a bunch of chaplains, and it was much more comprehensive, but didn't have all of the things that Modal and her colleagues had thought about. So we looked at those, and then we, as investigators, and particularly people like me who are sort of in this funny borderline between religion and medicine, had our own conceptions of what spiritual needs patients might have. We put all of these together, tried to develop an initial set of potential items, ran them through some focus groups of patients who were ambulatory oncology patients at St. Vincent's in New York. And then we did successive waves of interviews with what's called cognitive pretesting to try to refine those questions with our patients. And our final version had 23 items, and what we tried to do, and this is not easy, but I think very important in terms of the care we give to patients, to define 3 overlapping but perhaps distinct domains. One we called psycho-spiritual, which we thought was really the focus of Alison Modal's instrument. But then another group that we wanted to call spiritual proper, with perhaps with a capital S, and then another group of concerns that were religious, right? And these are distinct. So, for instance, I've maybe some of you have, like me, if you're a religious person, complained about the people, increasing numbers of people who describe themselves as spiritual but not religious. A Franciscan friar colleague of mine once said, yes, but we also have that problem of all those people who are religious but not very spiritual, right? these are distinct sets of domains. They're overlapping, but I think distinguishable, and so we tried to do that. We also tried to improve on what Modal had done as a scale, and we tried to make this an ordered categorical scale so that we could actually have some better measurement. So here are the items that we called psycho-spiritual, if you will. How much would you like help with getting in touch with patients with similar illnesses? Relaxation or stress management. Learning to cope with feelings of sadness. Sharing your thoughts and feelings with people close to you, or worries that you have about your family, right? So those sort of border on the spiritual. They're not really, we're not really trying to diagnose any sort of psychiatric syndrome here, but they're real needs that patients might have. The spiritual needs subscale was more properly oriented to those questions of transcendence that we tried to talk about. So how much would you like help with finding meaning in your experience of illness, finding hope, overcoming fears, with personal meditation or prayer practices, your relationship with God or something beyond yourself, becoming closer to a community that shares your spiritual beliefs, coping with any suffering you may be experiencing. And how much would you like to talk with someone about the meaning and purpose of human life, dying and death, finding peace of mind, resolving old disputes, hurts, or resentments among family or friends, finding forgiveness, making decisions about your medical treatment that are in keeping with your spiritual or religious beliefs. So these, we thought, were things that are commonly addressed by religions, but are not specifically religious themselves, and yet relate to questions of a transcendent nature. And then the specifically religious needs subscale. So how much should the following resources offered by religious or spiritual communities, how much would they be of benefit to you? Visits from clergy of your own faith community, visits from the hospital chaplain, visits from fellow members of your faith community, religious rituals such as chant, prayer, lighting candles, incense, anointing, or communion, finding someone to bring you spiritual texts such as the Torah, Quran, Bible, Analects of Confucius, or Tibetan Book of the Dead, right? So these are specifically religious kinds of needs that patients would have. And sometimes all of this gets lumped together, but we tried to sort of say that, well, they're distinct, and if we're to address the spiritual needs of patients, we ought to be able to name these things and know what it is we're actually trying to address and do for them concretely. So we'll give you, this was just the validation study. We had a largely white population at St. Vincent's, but some diversity. Again, they were all cancer patients, the preponderance of breast or other. Mostly Catholic, as you might imagine, at St. Vincent's, but a wide variety of other religions. Again, I told you, even if you are Catholic, if you're in Chelsea or Greenwich Village, 70% describe themselves as spiritual but not religious. Only 31% said they attended religious services weekly or more, and 15% said that their spiritual needs had not been met. Our psycho-spiritual needs scale distribution got a pretty good spread, which we thought was good. It had intercorrelations between items, which were all on the good side, and a Cronbach alpha that had hung together as a subscale pretty well. And it had pretty good retest reliability at 2 weeks. Our spiritual needs subscale also had a good distribution. We were very pleased by this. Again, good intercorrelation between the items. Again, a very good internal correlation on the Cronbach alpha, almost too good. And then a good retest reliability with a correlation coefficient of 0.68. And then our religious needs subscale. Now it's skewed because there are a lot of people who said they had none, no religious needs that needed to be addressed. But otherwise there's a pretty good distribution despite that skew. And again, intercorrelations were good, and a good Cronbach alpha, and a very good test-retest reliability on this. We thought that the way we developed this was to try to distinguish those different kinds of domains, and we think we have done pretty well with our internal reliability on each of those subscales, but we wanted to say, how validly are we actually distinguishing these domains? And there's only one question out there that we knew of before that had been used a lot, and that's, have your spiritual needs been met? And we tried to sort of test the association between our scale scores and that question. We got what we had hoped for, that there was really almost no correlation between the psychospiritual needs and have your spiritual needs been met. So those questions about how much do you need stress management, for instance, doesn't correlate with have your spiritual needs been met. But the spiritual needs scale does very much, was associated with that. And the religious needs was moderately associated, as we would have predicted, so that we think that we have, while these overlap, effectively distinguished between those. So we were able to conclude, and I hope we can convince you that it's valid, internally consistent, and reliable for assessing spiritual needs. We're doing some other things with it. We've been trying to translate it into other languages. We have it in Spanish and Chinese. The Chinese, interestingly, would prove to be very difficult. There are two words in Chinese that sort of translate as spiritual. Neither works very well. I'm trying to remember if one is Jingshen, I think. I can't remember them at the moment. And Xingling, I think. And they don't quite fit Western concepts. And what we've wound up with is something in which we, in order to get our validity that it associates with the question of your spiritual needs met, we have even more overlap, and we lose some of that distinction between psychospiritual, spiritual, and religious needs in the Chinese population. So there will be variations on this according to language and culture. I have some colleagues in Brooklyn who are translating it into Russian, and colleagues now in a cancer center in Sao Paulo, Brazil, who are translating this and doing a validation in Portuguese for this instrument. We do need to work on confirming it in larger populations, validating it in non-cancer populations, and then, of course, to see if it's responsive, to see if we can actually intervene. So if the chaplain does visit, if the spiritual needs are attended to by nurses or physicians, does this actually make an impact on the scale scores? We don't know any of that yet. There's a lot of work to do. I want to turn at the end to more of the cautions, though. So I gave you some cautions at the beginning, some positive things. Here are some more of my cautions about measuring spirituality in healthcare. One set of studies that I think have been really well done from an epidemiologic point of view. People have tried to control for health-related behaviors that, like smoking and drinking, that might be associated with religiosity. But a number of studies have shown that patients who attend religious services on a regular basis have better health outcomes. It's even been, there's also a problem you have to worry about, that patients who are sick don't attend religious services, so there could be some confounding. So people have rephrased the question of when you were well, how often do you attend religious services, or done these as long-term follow-up studies over 20 years where they're taking baseline data and seeing what happens. And various number of studies have shown about a 23% decrease in the relative risk of death for people who attend religious services on a regular basis. So I think that from an epidemiologic point of view, this is true. I think it's been validated, shown in a number of well-done studies. The problem comes in the interpretation. What do we make of this? What's causing this? This is an association, and we don't know what the causation is, right? Could it be that there's a relaxation response that people like Benson here at Harvard have talked about for people who attend religious services on a regular basis? Could it be the community support from somebody who attends religious services on a regular basis? Could it be the sense of purpose and hope in the face of illness that comes from being part of a religious community? Could it be the prohibition on unhealthy behaviors, even though they've tried to control for that? Could it be the sort of sense of discipline that comes from being part of a religious community that may help with compliance with medical treatments? Could it be the way in which meaning in the face of suffering is something that a religious community can help to impart to these people? Maybe. It could be any of those things. And you don't need a religion to have any of these things. On the other hand, show me something that gives you a relaxation response, community support, a sense of purpose of hope, prohibits unhealthy behaviors, gives you discipline, and helps you find meaning in suffering, and you're probably going to call it something very close to a religion, right, if it does all those things at the same time. But the other caveat is that there are some people who have leaped from this, and I think very prematurely, to say that, well, since it's good for your health, we ought to tell people that they ought to be attending religious services on a regular basis, just like we tell them they ought to not smoke and they ought to wear seatbelts when they're driving, right? Wrong. Wrong. It's not a warrant to urge spiritual development as a medical indication. The first thing is that association is not causation, right? Nobody did a randomized controlled trial of taking people who weren't going to church and said, now you're going to go to church and we're going to make your health better for the next 20 years, right? Again, that question of intrinsic versus extrinsic religiosity may have a good deal to do with this. Second, real cautions about the intimacy that's part of religion and spirituality and the Aesculapian power of the white coat, that we shouldn't, just as I don't think any of you would say to somebody, it's true that if you're married you live longer. I don't think we should be telling patients they ought to get married for the health benefits. I don't think we should be telling patients they should go to church for the health benefits. And from a theological perspective, I don't think a pastor wants his or her church filled with people who are there for the health benefits, right? While it's true, I don't think it gives you a moral warrant for telling the patients they ought to start going to religious services on a regular basis. By the way, it's true across denominations, so it doesn't matter whether you're Buddhist, Jewish, Muslim, or Christian, this carries. Second set of cautions. If any of you have been aware of some of these randomized trials of intercessory prayer, there were some early ICU trials that were supposedly positive. These are studies in which a group of people is designated to pray for patients in an intensive care unit. And they allegedly showed positive outcomes. I think these are flawed scientifically, ethically, and theologically. From a scientific point of view, just think of actually trying to have a control group. Try to randomize the patients in the ICU at the MGH to being prayed for and not prayed for. Don't you think there's at least one janitor in the basement sweeping the floor, praying while he's doing that for every single patient in the hospital, right? How do you prevent people from being prayed for? Second, what's the scientific construct that we're going to try to generate for prayer? Did 2 Buddhist nuns at 100 meters equal, 50 Carmelite monks at 5 miles? I mean, is there a dose-response curve to this? It just doesn't make any sense. The scales that they developed were problematic in that they showed, they weren't really validated, and the positive outcomes were, such that, if you really looked at it, people got less Swan-Ganz catheters, but the same number of people died in both the control and the outcome group. But the scale turned out to be positive, so that doesn't make much sense if there's no impact on mortality. You're sort of saying, well, God cares enough not to put Swan-Ganz catheters into people, but not enough to save their lives. This doesn't sort of make sense if that's what you think is happening. Secondly, from an ethical point of view, if you are a religious person, I would find it very problematic to randomize people not to be prayed for, right? Just from a moral point of view. And lastly, from a theological point of view, these kinds of studies, I think oddly, again, it's the sort of medical positivism gone amok, right? That we have to, everything comes under science, right? Where we make science the judge of God rather than God the judge of science. We're reducing prayer to a therapeutic nostrum, something else that's in the doctor's black bag. And I don't think that we want to have the conclusion that God is somehow absent from the people who were prayed for and still died in the intensive care unit. The God, at least that I believe in, is with those who live and those who die. And finally, when the best of these studies was actually done, the results were, as I would have expected, when you do it in a really good way, absolutely flat. That God makes his sun to rise on the just and the unjust. And there was no difference in the best of these studies. So I think this sort of aspect of trying to measure spirituality in healthcare is terribly misguided for scientific, ethical, and theological reasons. One more, just dangerously perhaps a little close to home here. I don't know where Michael is, but spiritual intervention and medical costs. Again, there's this great temptation in the current environment where everything is about cost containment, and ACOs are going to amplify that. I think it's nice to show that spiritual intervention leads to decreased length of stay and less MICU use and lower costs. And you might say, well, we can use that as a good bargaining chip to try to get more, money for the chaplain service in our hospitals. But I've got real worries about this and real cautions. The first is the sort of economic reductionism that this could easily slip over into, that chaplains are valuable if they save money. And the worry would be that if there's more utilization, that then the chaplains are deemed as not being valuable, and therefore we get rid of them. I think I'm just a little cautious about this. It's nice if you can show it, but I do have some worries about the sort of negative implications if the studies are misinterpreted and misused. I think that it is natural for spiritual issues to arise, particularly in the care of patients at the end of life. I think they're often the elephant in the room, that when the patient is dying, questions of meaning, questions of value, and questions of relationship arise naturally. Brokenness in body reminds people of their brokenness in spirit, and all of us who are in health care, particularly at the end of life, are aware of this. My sense is that we can have what I've called a biopsychosocial spiritual model of caring for the patients, that the patients bring with them a spiritual history as well as a biopsychosocial history. And they have a present spiritual and biopsychosocial state, and maybe what you're trying to do is intervene to modify that spiritual state and hope that that is in dynamic relationship to their biopsychosocial state, and that this will be what carries them over in and possibly through death in their care. And that we can think about the relationship between all our measurements, the way they fit into a model like this, as long as you obey the proper cautions that I've tried to lay out for you, and suggest that we can do better in terms of our research. We can do better instruments, measures of patient sense of meaning, value, and relationship. We can ask them more about whose role they think it is to address their spiritual needs. We can look at interactions between those four spiritual domains in traditional medical phenomena, look at the efficacy of spiritual interventions, the spiritual significance of patient-professional relationships, better tools for taking spiritual histories, think more about what we bring to the table, our own spirituality as clinicians, think about the spiritual care of families after death, make room for humanities research in our medical journals so that the copy editors aren't asking who Aristotle is. And these are things that we ought to be pursuing, and I think that's plenty to keep us busy for quite a few years, because human beings are not merely their bodies, because patients are asking for attention to their spiritual needs, and particularly at the end of life, I think there's no other possible healing if a person is dying except in a spiritual sense, where we can bring their relationships perhaps into better harmony. The bottom line on all of this from a sociologist is not everything that counts can be counted, and not everything that can be counted counts. So, thank you.
and how this overlaps, and how sometimes I find that what they're wanting is we become their community. They become so medicalized that we become their community, and that sort of differentiation between spirituality and religion. There's a way that we become their religion in some way. And I just wondered if you had thoughts about that.
Sure. The question is the extent to which the healthcare professionals and the team in the hospital becomes the spiritual community for patients, particularly those who are chronically ill for long periods before they die. Yes, I think that can be to some extent the case, which is part of the reason why I think it's important for us to begin to look inwardly, and this is even more dangerous, at our own spirituality, what we bring to the table, what state we're in. Abraham Heschel, talking to the American Medical Association in the early 1970s, said that to heal a person, you must first be a person. So if we can do a better job of nurturing our own personal development, we may be better as a community for those who are chronically ill. It often means that, for instance, the chaplains in the hospital become the actual spiritual caregivers, although, particularly from a religious perspective, in concert with, though, and I think this is important, other members of the team who recognize that they have a role in the spiritual care of patients. But beyond that, I think also we can do a better job, and this is a challenge that I know Stanley Hauerwas at Duke is very good at putting to the churches. You know, where are you in visiting the sick? Amos, I'm blocking on his last name in Birmingham. Bailey, you know, in his hospice had various churches that adopted beds, right? So the external the person who's in the hospital shouldn't be isolated from the larger community either, so that the religious community, the community at large, can do a better job of what, at least in my tradition, used to be called one of the corporal works of mercy, visiting the sick, and again we've tended to sort of ghettoize patients and not recognize the community as broader than the community in the hospital as well.
I just wanted to say two things. One question was, thank you. I want to thank Michael Melville, professor of the preschool. Raise your hand.
Oh, there he is. Okay. I didn't see you in the corner when I was talking about those studies. Sorry.
You're arranging your visit here, so I just want to thank you.
Thank you.
I guess one thing that I was thinking about throughout your talk is that for people who think of their spirituality in terms of relationships with other human beings, being in relationship, that the questions they're thinking about, they might not perceive it as spiritual, they may think about it more as emotional, psychological, and it almost seems, I can imagine the spirit that you talking, you and others wanting to promote increased awareness of spirituality in medicine. It just seems to make sense that you would kind of work together with those who are trying to increase psychological well-being.
Yes.
Psychologists, because in some ways there's so
Yes.
much overlap.
Yes.
Forces
Yes. Yeah.
together
Yes.
is powerful.
Yes. So the question is, reinforcing the sort of overlap between what I've called the psychospiritual and the spiritual and the religious domains of need. So this is precisely what our instrument was trying to do in some ways, is first of all, to name these needs explicitly for patients, and to not put and to make sure that the vast majority of the questions don't mention anything about religion or God, right? Those are the religious, explicitly religious needs. Yet we want to distinguish them because there are particular roles where people specialize. But yes, they do absolutely overlap and interrelate to one another. So the person who is feeling a deep regret over the fact that they are estranged from their family may in fact be feeling very stressed and anxious, etc. So that your suggestion that that we work as a team on this is something that obviously hospice and palliative care understand, and we wish the rest of medicine would understand that there's a role for the psychologist and the psychiatrist on the team, there's a role for the nurse, there's a role for the physician, there's a role for the chaplain, and all of them have particular expertise, but all of them have some expertise that overlaps and help and reinforce each other in their care for the patient. And I think that's exactly the way that we ought to move and amplify in the care we give to patients at the end of life, but also ought to try to teach everybody in rheumatology and surgery and everything else about this approach, because I think it's the proper one to treat patients as whole persons. Yes. Yes, well, the question is, we put the role of the chaplain's visit under religion. Yes. I think that certainly, again, there's an overlap, so that, a lot of what chaplains do is deeply spiritual and even attend to the spiritual needs of patients who are not religious. But in terms of trying to sort of carve out those domains, we wanted to say this tends to be more of a religious need, even though you're absolutely right that there is overlap between those two. I mean, there was, a correlation between spiritual needs and chaplain visits. And again, it's sort of the sense that there's subspecialization, but bleeding over in terms of roles. So the nurse might be, very much attending to some of the spiritual needs, but the person who would be better equipped to do particularly the religious aspects of that might be the chaplain, but both working in concert together for the benefit of the patient.
I wonder if you could say something about the role of education in terms of healthcare providers offering spiritual care. We're lucky here at Mass General to have a program that addresses those educational needs, but everyone can speak to it. Can everyone do it? What's needed?
Sure. So the question was about education and the spiritual needs in the spiritual care of patients. Absolutely, I think that there's a great need for education about spirituality and healthcare. Some of this begins in medical school. It can't end there. There's enormous variability in the quality of what happens in medical schools. Some of it is, we bring in a Buddhist and a Hindu and a Catholic and a Protestant and a rabbi, and they talk about religion and healthcare, and that's it. Some of it is more dynamic, so that one of the things we did at Georgetown was to have the medical students shadow a chaplain for an afternoon so they could see what things look like from the other side of the bed. There are also, and I think it's here in the Harvard system for advanced training, clinical pastoral education for clinicians, which is extremely valuable. I did a little bit of that in an informal way myself, and I can tell you it's a wonderful teaching experience for clinicians to present a verbatim to chaplain students and have them ask, Well, exactly whose agenda was that when you asked that question, doctor? That this can be, again, helpful in an educational way. So I think plenty has to be done. It can start in medical and nursing school, can't end there. The information is part of it, but experiential learning has got to be a part of it, and to some extent, just beginning to break down the barriers that exist, I think, is part of the educational effort.
My question is about the evolution of the medical practice for physicians. I've had the privilege of interviewing specialty physicians who have practiced for more than 30 years. The evolution of what's going on in medicine, particularly with a focus to spirituality and their practice. And almost to a person, they say that as more and more knowledge has become valuable and the craft has become more demanding, not intentionally, but they've been constrained in terms of the kind of time they can spend on this. And in looking back, it's more in a sort of more negative look. It would be that years ago, when we didn't know very much, we had more time to spend on these issues.
Mm-hmm.
And I noticed that from them, they had this feeling that this has happened to me, not something that I would choose. Where do you think this all will evolve if you look ahead 20 or 30 years from now, and how this outcome might happen?
Yes. The question relates to the decreasing time that clinicians have to attempt to address these kinds of spiritual needs and the pressures that they're feeling and the disappointment that they can't address these needs, particularly as things have become more specialized. Well, yeah, I think that it's some of this sense that we've sort of hit bottom that's actually paradoxically part of the rise of interest in spirituality. So that, and even if you want to, again, look at the bean counters, I'm trying to get David Meltzer, who's got a PhD in economics and is an internist and hospitalist at the University of Chicago, to do the study. I'm sure there's a J-shaped curve. The more they try to get you to be efficient, right? So the less time you spend with patients, the less money is actually being spent per patient. Except when you have so little time that all you can do is refer them to subspecialists and tests and do tests, that the costs are going to rise. And I think the cost, part of what we have to take account of is the human costs of not addressing the spiritual needs of patients are so profound for both clinicians and patients that the pressure to be more efficient has actually become counterproductive to healthcare. And that's part of why there's a rise, I think, in interest not only from patients but also from practitioners.
Thank you so much.
Thank you.